Hello, everyone, and welcome back to our session. This will be our session 2 for the Emergency Department Nursing. This would be a continuation for the topics from session 1. Okay, to begin with, we will start with our first presenter for this session 2. She graduated in 2006 from the Medical College of Northern Philippines and working in the Accident and Emergency Department of Pujar Hospital since 2009, and currently a team leader and a preceptor of new staff in the same hospital. Let us all welcome Miss Renalyn Malana. Ma'am Renalyn.
Hello, everyone. Good morning, good afternoon, good evening to all of you. Uh, I'm Today I'm tasked to discuss with you the hazardous materials. In every facility, we encounter different types of hazardous materials that may harm anyone. In addition to that, we also use these hazardous materials in our everyday life, like in our home. We are using cleaning materials that are highly corrosive, like muriatic acid, the liquid that you are using in the uh, toilet. Um, the next slide, sir. In this photo, this is a danger sign that can be seen a vehicle transporting. This one we can usually see in any vehicle transporting any type of hazardous materials like flammable liquids or solid, corrosive, and explosive. Okay. Hazardous material is defined as any substance that can risk or harm the health of every individual and community, the environment, or property. The prevention of exposure of hazardous materials are highly important. Hazardous material safety is campaigned by different federal agencies like Department of Transportation, Occupational Health and Safety and Act, or OSHA, state agencies, laws, and regulations. Hazmat teams are trained staff that is specifically handling dangerous goods, which includes the following: radioactive, flammable, explosives, corrosives, iodizing, biohazards, toxic, and pathogenic that needs caution in responding hazmat because the result can be deadly and responders should be avoid themselves to be victims. The response, sorry, the responders should wear appropriate clothing and personal protective equipment. During hazmat incident, the main priority is to protect themselves from any type of exposure and contamination. This is the list of different types of hazardous materials that we everyone should be familiarized so that we know that these are really highly risk to our health and environment. Uh, First is the explosives. Description: mass explosive. The example is dynamite. Projection hazards, flares. Mass fire hazard, minor hazards, very insensitive or extremely sensitive. The example of these are the dynamites, flares, display fireworks, ammunition, blasting agents, and explosive devices. Second is the compressed gas. These are gases which are highly flammable or non-flammable compressed gases, poisonous. Example of this is propane, helium, fluorine, and compression. Third is flammable liquids. First is the flammable, which the flash point of temperature is 141 degrees, and combustible, the flash point is 141 to 200 degrees. The example of these are gasoline. Fourth is the flammable solids. Flammable solids, spontaneously combustible, dangerous when wet. The example of these are ammonium, titrate, wetted white phosphorus, and soju. Fifth, oxidizers and organic peroxides. The description is oxidizer, organic, and the example is ammonium nitrate and methyl ethyl ketone peroxide. Number six is the toxic materials, poisonous materials, and infectious agents. Example is the potassium cyanide, anthrax virus. Number seven, radioactive materials. There are three types. Radioactive type. Example of these are uranium. Corrosive material. The extraction of the human body corrodes steel at a rate of 0.25 inches yearly. The battery fluid. Miscellaneous, it is a material that can pose hazard during transport but doesn't meet the criteria of other classes. The example of this is polychlorinated biphenyls. The next is the steps in human health risk assessment. In every hazardous incident, we should know what types of hazardous materials in order that we can know how to deal with it. And then, of course, we need to know the dose or the amount of the hazard materials that being exploded. And then next is the exposure assessment. We should determine the rate and then the risk of the hazardous materials. And then fourth is the risk characterization. Next slide. How does hazardous materials enter to the body? Okay, first through inhalation, absorption, and ingestion, and finally penetration. The first aid for this is inhale some fresh air, rinse your mouth immediately, wash thoroughly with soap and water, irrigate with tap water immediately. The symptoms, possible symptoms are skin irritation and eye, difficulty of breathing or dyspnea, dizziness, headache, nausea and vomiting, and also we have chemical burns, birth defects, disorders of the lung, kidney, or liver. And finally, how we are going to protect ourselves from exposure. Of course, as we always said, always wear our PPEs, gloves, goggles, gowns, and masks. And then from the engineering controls, decrease the contamination to hazardous material by using tongs, brushes, and dustpans. And work controls, checking and recording the temperature of volatile chemicals is one way of avoiding or reducing the exposure to substances. That's all for hazardous materials. Next, I will be discussing also decontamination. Okay, in this video, you can see the sample of the contamination. Oh, so I hope the video is very informative, as sample of decontamination procedure. Decontamination is the process of removal of hazardous material from the staff, equipment, or the environment that it is important to our health and safety. It is important to remember that immediate decontamination within the first 1 to 2 minutes after chemical exposure is most effective. This early intervention will save lives. There are methods to follow in decontamination. Why to decontaminate? It will help to protect the staff to be uh, contaminated from hazardous materials that can transfer to the protective clothing, respiratory equipment, instruments, cars, and other items in the area. It protects by controlling the contamination that are clean. It protects the community or family by preventing the transfer of chemicals from working area. And it also protects from future health problems that can cause by exposure of hazardous material. Decontamination plan. In every situation, there should be developed decontamination plan as included in their site safety plan. That prior entering the area of exposure to any hazardous materials, the staff are aware of the following: decide the number of decontamination stations and its layout, establish the equipment needed, establish the appropriate decontamination methods, establish the procedures to prevent the clean areas to be contaminated, and determine the methods of removing the PPE to decrease the chances of contamination, and decide the disposal of clothing that are contaminated. This can be revised whenever there are changes of any exposure to hazardous materials. Decontamination methods. Decontamination must be carried out to all personnel, clothing, equipment, and sample before leaving the site of exposure. It can be done through the following: physical removal. Contaminants can be removed physically by wiping off, rinsing, uh, at as you can see in the video that posted, chemical removal and also wound decontamination. The decontamination procedures: first, set up the decontamination areas. These include the primary, corridor, secondary, and observation area, and the medical triage. It involves the thorough washing to remove contaminants. Second is the conduct a decontamination triage. This can be done if there is much casualty situation. It is also important in mass casualty incidents that should not be confused with the medical triage. Decontaminate patient is most effective if victims first remove their clothing, since this alone may eliminate as much as 80 to 90% of all contamination. Fourth is the segregate patient from observation and treatment room. In this situation, we have to give priority to elderly and children, and to guide them to the observation room or the primary decontamination. Fifth is the release the patient after clearance. Prior to release, it is evidence of residual of contamination should be examined by trained medical personnel. Secondary decontamination is necessary to perform as needed. Okay, that's all, guys.
Thank you very much, Ma'am Renalyn, for that informative presentation. We would now proceed to our next presenter. Uh, he's a graduate of BSN Batch 2008 from STI Academic Center in Global City, Taguig. He has worked in several hospitals in the Philippines, including St. Luke's Medical Center in Global City. He also worked overseas in countries like Libya and Ethiopia, and currently working as an oncology nurse in Dutch Antilles Caribbean Islands. Let us all welcome Mr. Harven Joe Limpasan.
Thank you, Sir Wilson. Again, good day to all fellow nurses who are part of this webinar from the Philippines, Middle East, and Europe. So, biological warfare is uncommon. It can be devastating and also life-threatening for us working in the healthcare. It is a must that we nurses must be equipped with knowledge about biological agents and how it is being used as a weapon in biological warfare. So, what is code CBR? In Australia and some parts of Canada, they use the code CBR to alert and prepare the appropriate response to incidents related to biological warfare. Next, please. So, code CBR stands for chemical, biological, and radiological incidents or initiated attacks, such as in bioterrorism. Also, some uses CBRN to include nuclear incidents. In most parts of United States, they utilize code orange, which is the code for external disaster, to cover CBR incidents. Next, please. So, biological warfare. During World War I, the Germans used a number of human and animal pathogens. During World War II, the Japanese military used biological agents in the Soviet Union, Mongolia, and China. In late 2001, after the explosion of the Twin Towers of World Trade in the United States, anthrax was dispersed through the United States Postal Union and infected a number of people. Next, please. So, bioterrorism. Next, please. According to the Occupational Safety and Health Administration of United States Department of Labor, bioterrorism is the intentional use of microorganisms to bring about ill effects and death to humans, including livestock or crops. Next, please. So this is the universal symbol for biohazards, which includes infectious agents used in biological warfare. Next, please. Biological agents. So according to the World Health Organization, biological weapons are microorganisms like virus, bacteria, fungi, or other toxins that are produced and released deliberately to cause disease and death in humans, animals, or plants. Next, please. So we have three categories for biological agents. Category A includes high priority agents that pose risk to national security because they can be easily disseminated or transmitted. They can result in high mortality rate and have potential for major public health impact and might cause public panic on social disruption. Require special action for public health preparedness. Next, please. So these are the examples of biological agents in category A. Anthrax, botulism, smallpox, tularemia, viral hemorrhagic fevers, such as Ebola, Marburg, Lassa, and Machupo virus. Next, please. In category B, this includes those cause moderately easy to disseminate, results in moderate morbidity rates and low mortality rates. They just require specific enhancements of the CDC's diagnostic capacity and enhanced disease surveillance. Next, please. Next slide, please. So these are the examples of category B biological agents: brucellosis, epsilon toxin, food safety threats from Salmonella, E. coli, and Shigella, glanders, melioidosis, psittacosis, Q fever, racing toxin, Staphylococcus enterotoxin, typhus fever, viral encephalitis, and water safety threats. Next slide, please. So biological agents, category C, these are the third highest priority agents, which includes emerging pathogens that could be engineered for mass dissemination in future because of their availability, ease of production and dissemination, potential for high morbidity and mortality rates, and major health impact. Next, please. So So example is the Nipah virus and hantavirus. Nipah virus is also from the rats, and hanta is from the rodents. So recognizing biological agents. So we will not be discussing all the specifics of the biological agents. We'll just do one practical practice exercise that will be for anthrax. So anthrax causative agents, as you have seen in the previous agents, it is caused by the Bacillus anthracis, spore-forming bacteria. The mode of transmission can be in three ways. It can be in cutaneous transmission, respiratory, and gastrointestinal. Cutaneous will be contact of the spore. Respiratory will be the inhalation of the spore, and gastrointestinal will be ingestion of the spore. So incubation period, it can be from 15 hours up to 12 days. 15 hours is for gastrointestinal ingestion. So signs and symptoms, it will include flu-like symptoms, skin changes, nausea, hematemesis, to name a few. So prevention, as discussed earlier, we need to do appropriate isolation precaution, infection control, hand hygiene. Next, please. So according to the Medical Journal of Australia, for the CDR response, emergency department should include policies and plans. The design and the equipment of the emergency department should be appropriate, such as having decontamination area, isolation area. Personnel should be augmented in case of bioterrorism attacks, occupational health and safety, further surveillance, and further education and training for healthcare teams, especially the nurses. Biological warfare and biological agents. So this is just an additional information. In the Philippines, we have the House Bill 4458, which was proposed for the establishment of an integrated chemical, biological, radiological, nuclear resiliency program. That will be all. Thank you.
Thank you very much, Mr. Harvin, for that detailed presentation. We will now proceed to the next presenter. He is a registered nurse and a graduate of University of Cagayan Valley and currently working at Apari District Hospital as an operating room supervisor. Let us all give a virtual round of applause to Mr. Charchay Sirinupong Jr. Mr. Charchay.
Thank you, sir. Thank you, Sir Wilson. Good day, everyone. I'm assigned to presenting the natural disaster. During times of natural disaster, hospitals play an integral role within the healthcare system by providing essential medical care. So what is natural disaster? Natural disaster is a major adverse event resulting from natural process of the earth. Example includes floods, volcanic eruptions, earthquakes,
tsunamis, and other geological processes. A natural disaster can cause loss of life
or property damage and
typically leaves some economic damage in its wake,
the severity of which depends on the affected population, resilience, or ability to recover. Next slide, please. Emergency Department. The Emergency Department plays a crucial coordinating role during disaster situations, both external to the hospital and in the event of exceeding its surge capacity. The ED shall develop the hospital's emergency preparedness plan in collaboration with the other departments in the hospital and plan for its activation based on an alert system in place. Next slide, please. Disaster nursing. The adaptation of professional nursing knowledge, skills, and attitude in recognize and meeting the nursing and medical needs of disaster victims. Next slide, please.
Preparation in emergency department. The emergency department nurse is responsible for the following.
First,
making sure as many nursing personnel as possible report for duty, assigning them to specific areas or rooms, instructing volunteers and ancillary personnel.
Next slide, please.
Providing breaks or periods of rest for triage nurse and those working in resuscitation and minor treatment areas. Communicating the need for additional personnel to whoever concerned. And periodic checking of supplies.
Next slide.
Policy of natural disaster management. The equipment should be sufficient at least for 50 victims, and the things should be replaced after use. When information of disaster is received, trolley should be arranged at the emergency gate to receive the patient. Extractor vans should be posted at the gate to transfer the patient to emergency.
Next slide, please.
Information should be sent to all concerned personnel for supply of extra equipment. Extra staff should be posted to emergency from other disease. Disaster cupboard should be kept open and needed equipment should be checked. Triage at the entry of the emergency according to the condition of the patient. Natural Disaster Preparedness Team. The Natural Disaster Preparedness Program must identify each possible disaster and explain how to recognize it, when it shall actually become a threat, and who is to do what, when, and how. Member of the team should come from all ranks of the facility personnel. A team should be formed to handle each and every disaster that comes up as opposed to a separate team for each type of disaster. Since most hospital facilities are open 24 hours a day, 3 teams should be formed, 1 team for 8-hour shift. Each should have some related knowledge and or experience in the various potential emergency situations. The member of the team would be fully trained to handle all emergencies and would receive additional compensation on an hourly basis to be added to their base wages. Education in emergency procedure as in basic safety should start with the employee's handbook. Small and yet easily seen face-on signs giving the telephone number should be attached. Fears that can arise during natural disaster management. Non-ability of a disaster manual, insufficient medical or non-medical staff, less time for clerical work, compliance with the disaster plan, communication difficulties, shortage of supplies and equipments. Factors affecting the nursing care during natural disaster. Shock and anxiety among staff, worries about their own families, mode of arrival of casualties, time limitation for documentation and charting, disruption of normal communication. Influx of staff in a familiar situation, sudden increased demands of supplies and equipment, and lack of identification of victims. Qualities required for a nurse to work in a natural disaster. Sensitive to the problem, understanding in nature, caring, emotional stability, strictness in responsibilities, leadership ability, teamwork efficiency, including technical skills and judgmental skills. Thank you for listening.
Thank you very much, Mr. Charchay, for this wonderful presentation. We will now proceed to the next presenter. She is a graduate of Lyceum of Paris and a registered nurse since 2011 and currently working as an operating room staff nurse at the Medical Center Taguig. Let us all welcome Ms. Maria Irish Susain Yoldi.
Good afternoon, guys. I am tasked to discuss about post-traumatic stress disorder. So, what is PTSD? PTSD is a psychiatric disorder that may occur in people who have experienced or witnessed a traumatic event such as a natural disaster, a serious accident, a terrorist attack, war or combat, or rape, or who have been threatened with death, sexual violence, or serious injuries. People with PTSD have intense disturbing thoughts and feelings related to their experience that last long after the traumatic event has ended. They may relive the event through flashbacks or nightmares. They may feel sadness, fear or anger, and they may feel detached or estranged from other people. People with PTSD may avoid situations or people that may remind them of the traumatic event, and that they may have strong negative reactions to something as ordinary as loud noise or even an accidental touch. The signs and symptoms of PTSD falls into four categories, which is intrusion, avoidance, alterations in cognition and mood, and alterations in arousal and reactivity. Okay, so again, symptoms of PTSD fall into four categories, which is re-experiencing symptoms or intrusions, avoidance symptoms, arousal and reactivity symptoms, and cognitive and mood alteration symptoms. So, in intrusion symptoms, it includes the flashback, bad dreams, frightening thoughts. In avoidance symptoms, it includes staying away from places, events, or objects that are reminders of the traumatic experience, avoiding thoughts or feeling related to traumatic event. Arousal symptoms include being easily startled, feeling tense or on edge, having difficulty sleeping, having angry outbursts. Cognition and mood symptoms alterations includes trouble remembering key features of traumatic events, negative thoughts about oneself or the world, distorted feelings or blame, loss of interest in enjoyable activities. So to diagnose that with PTSD, the adult must have all of these symptoms. Like for re-experiencing symptoms, it needs one of the following symptoms. In avoidance, we need at least one. In the cognitive and mood symptoms, we need at least two. And the arousal and reactivity symptoms, we need at least two of that symptoms. Okay, next, sir. Okay, PTSD treatments and therapies. So the management of PTSD are most likely medication and therapy. But the first line of treatment are behavioral therapies. For example, is the cognitive processing therapy, which includes the specific type of behavioral therapy that helps patients learn how to modify or challenge unhelpful beliefs related to the trauma. Next slide, sir. Next is the prolonged exposure therapy. It's a form of behavioral therapy which teaches the individuals to gradually approach their trauma-related memories, feelings, and situations. Next is stress inoculation therapy, which involves teaching coping skills to manage stress and anxiety. And lastly, group therapy. So in group therapy, as we all know, it encourages the survivors of similar traumatic events to share their experiences in a comfortable and non-judgmental manner. Next slide, please. For medication, usually antidepressants like SSRIs and SNRIs are being prescribed. Methylphenidate can also be used for treatment, and low-dose atypical antipsychotic for those who do not respond in SNRIs alone. We also have our non-pharmacological treatments such as acupuncture, yoga, therapeutic use of animals, and eye movement desensitization reprocessing. That would be all. Thank you for listening.
Thank you very much, Ma'am Irish, for that timely presentation. You beat the time for like 5 seconds. Next, we would proceed to our next topic and presenter. She's a graduate of St. Paul University, batch 2005, and is currently working in the Ambulance Department of Emergency Public Safety Directorate of the Abu Dhabi Police, United Arab Emirates, and has about 15 years of experience. Let us all welcome Miss Joanne Jubail.
Good morning, classmates. So I am tackled to cover about critical incident stress management. As emergency staff, we are exposed to a wide range of distracting and horrendous events that tend to be detrimental to our psychological well-being. Uncontrolled stress can negatively impact our patient care. That is why numerous psychological trauma management programs are provided to help staff exposed to traumatic events. One is called CISM. Next slide, sir. So what is CISM? It is a crisis intervention to help emergency responders who have experienced and were exposed to critical incidents. It is comprehensive and with a wide range of interventions because it has multiple crisis intervention components that address each phase of crisis situation. It is also applied to individuals, families, organizations, and communities. Next slide. So, CISM can be used to address a vast array of critical incidents. Critical incidents include line of duty or work-related deaths, suicide of co-workers and colleagues, serious accidents and injuries, serious incidents that involve children, cumulative incidents. These are serious events that happen repeatedly. Person may become distressed due to continued exposure. Victims known to the personnel like families and friends, MCI or mass casualty incidents. We usually encounter this in pre-hospital like car pile-ups. It happens during foggy times and Hajj or Muslim pilgrimage. So what are the CISM importance? It reduces the effects of exposure to critical incidents. It encourages personnel to emote the impact of psychological, emotional, and cognitive symptoms. It is also reduces the chance of developing PTSD. It is reduce emergency turnover. So when people are stressed due to what happened, they are unable to focus to their jobs and eventually quit. And helps maintain sound decision making among first responders. So it helps reduce clinical errors, restore adaptive functioning skills of persons or group. Next, sir. As earlier as mentioned, CISM composed of range of components. Number one is we have pre-crisis stage interventions. Under this, we have pre-crisis preparation. This intervention occurs prior to a critical incident. It includes stress management and stress resistance education, such as instruction in relaxation techniques and strengthening coping skills with the difficult emotions and stresses. It is also development of peer support. Peer support from colleagues provide feelings of security and belonging that can reduce mental and emotional strain. The next component is acute crisis stage interventions. So under this, we have demobilization and consultation. It occurs immediately after the incident, usually lasts 10 to 15 minutes. So the goal of this one is to assist individuals in managing their preliminary reaction to the events. The next one is diffusing. It is the extension of demobilization and consultation. The goal is to recall about the critical incident, offer support, and allow the person involved to express any concerns. This typically lasts for 1 hour. Next one is one-on-one crisis intervention. The help given to an individual that has witnessed traumatic event. The goal is to guide each person back to the level of functioning prior to the incident. We have also family critical incident stress management. The critical incidents have devastating effects on families. So this supports the family, promotes patient-provider communication, and provides direction towards closure. And lastly, under this acute crisis stage is critical incidents stress debriefing. This is most frequently used to use component designed to accompany other components and should not be used as a standalone intervention, which this one will be discussed further by the next presenter. The last stage is the post-crisis intervention, which is the follow-up and referral treatment. Critical incidents have overwhelming effects on all parties involved. There may be need for long-term psychological treatment. That is why it is vital that follow-up and referral mechanism is established. That's all, sir. Thank you so much.
Thank you very much, Ma'am Joanne. Would like proceed for to our last presenter for this session 2, and he is working as a medical surgical nurse in Sheikh Khalifa Medical City, Ajman, United Arab Emirates. Let's all welcome Mr. Marvin Leo Celeste.
Thank you, sir. Good morning, everyone. So today I will be discussing about debriefing. I will be highlighting the roles of nurses in debriefing at disaster and emergency. So one of the vital aspects of emergency medicine management is communication after episodes of care to improve future performances through group reflection on the shared experiences. Next slide, sir. So what is debriefing? Okay, debriefing is a facilitated or guided reflection in the cycle of experiential learning. Debriefing was initially promoted by military, then it was utilized by the other high-stakes fields, which includes the aviation, and currently it was co-opted in the medical industry. In the healthcare, the purpose of debriefing is to promote discussion of work to process, facilitate reflection, and assimilate improved behaviors into action. So in this slide, I will be discussing the why, where, how, who of the debriefing and when. Next slide, please. So why? The objectives of the debriefing is to identify locations of optimal and suboptimal output, and then determining ways to enhance future team performance. And another objective of the briefing is to improve specific emergency department metrics or systems and to evaluate the environment in the emergency. Next slide, please. So for the who of the debriefing, so we will be determining the participants on the debriefing. So team members with or without external participants can be the participants during the debriefing. So the participants are the all team members who actively participate in the clinical event. It could be the physician leaders, the primary nurse, respiratory therapist, secondary nurse, charge nurse, and residents. Or it can be also the other members include pharmacists, social workers, and patient advocates. And for the facilitators, so in determining can be external or internal members, single or multiple, and trained or untrained. So facilitators can be the physician, team leaders, charge nurse, and alternate facilitators could be the other team members who are not leading the resuscitation. So for the facilitator, the nurse documenter during the code is often the good choice to facilitate or co-facilitate the debriefing because they can share some knowledge of when medications were administered for other critical actions were performed. Next slide, please. So the role of the nurses is to facilitate. Search nurses usually done the debriefing because usually when the resuscitation comes, the emergency department nurses and physicians normally return immediately to other patients where responsibilities can become more immersed in clinical work, but the charge nurse do not have specific patient assignment, so they are allowed to prioritize the clinical debriefing process. So charge and other than that, charge nurses have clinical knowledge and they have operational awareness and they also have understanding of team roles and expertise within their department. So how does the debriefing be done? So there are methods and phases done during the debriefing. And under the method, there is the plus delta. In the plus delta, it involves group-based reflection and assessment of what went well, what did not go well, and what participants need to change to improve care. Next is the advocacy inquiry and the cognitive autopsy. This engages participants in a deeper discussion to uncover underlying rationales for decisions, behaviors, or actions. And last for the methods is directed feedback. This is to address the specific gaps in individual performances. And for the phases, there are 3 phases for the debriefing. The first one is the description. The purpose of this is debating the format of the ground and rules needed to establish psychologically safe environment. And the next phase is analysis, discussion of content relevant to the objective, review of actual action, discussion of what went well and what did not. And last is the application to the future event, discussion of how to improve in the future and summary of take-home points. Next slide, please. So, when we will do the debriefing, so the timing for the debriefing is classified into 3. So hot, it is immediately done after the event. The next one is warm, minutes to hours after an event. And last is cold. This is done days to weeks after the event. So the advantage and the disadvantage of hot and warm is, first is the advantage. The entire team is readily available. Next is recall bias is minimized and urgent issues are immediately addressed. However, the disadvantage for the hot and warm is there is a limited time during the shift. Next is limited space to debrief. And last is emotional preparedness of the team to debrief. Next is the advantage and disadvantages of cold. First is advantage is availability of quantitative data and follow-up patient information and care. Next is ability to include non-participant. And the disadvantage is reassembling the entire team, potential alteration in the quality of discussion due to larger group format. And the last is identifying the location where to debrief. Debriefing can be done on site of the location where the event occurred. It can be also be done on site in a place not where the patient occurred or off site. And usually a separate location may allow tension to be diffused, enhance privacy, limit distractions, and to enhance participant comfort. That's all, sir.
Thank you very much,
Thank you.
Mr. Marvin, for the very detailed presentation. We would now go to our open forum or question and answer. Does anyone have any specific question to a speaker? Ma'am Mandarin, are you raising your hand? Ma'am Mandarin?
Yes, yeah.
Yeah. To whom will you address the
I'm
question?
gonna address my question to Mr. Harven about his lecture about the biological welfare and biological agents. Okay. What is the most important role does the nurse should take part in the bioterrorism preparedness response, Mr. Harven?
Thank you for that question, Ma'am Manilyn. I would say that our participation on how to contain the spread of infection plays a vital role in the emergency response. So by practicing infection control and isolation measures, updating our knowledge on certain diseases, and providing health teaching to our patients will be of great help for the emergency response by the healthcare team.
Ma'am Mandarin, does that answer your question?
Yeah, thank you, Mr. Harven, for addressing my question.
Any more questions? I think we can have 2 or 3 more because we already exceeded the 45 minutes. Ma'am April, are you raising your hand?
Yes, I would like to direct this answer to Mr. Marvin regarding the debriefing of nurses' role in disaster and emergency. So what content should be discussed during a debriefing to best enhance clinical care in the future?
Okay, ma'am. The focus of the briefing should be on individual, team, process, or system issues that, if modified, would benefit the next patient with a similar presentation. Specific content discussed during the briefing can include clinical management, technical skills, and teamwork, and also behavioral issues.
Any more questions, Ma'am April?
That's all. Yeah, I'm satisfied with your answer, Mr. Marvin. Thank you very much.
Thank you very much. Any more question? I think we can still entertain one or two. Ma'am Daisy, do you have any questions or?
Yes, please.
To whom gonna address the question, please?
I'd like to address my question to Ma'am Renalyn about hazmat and decon.
Ma'am Renalyn, can you please turn on your microphone? Ma'am Renalyn?
Hello.
Yes, ma'am.
Yeah. Yes. My question is, what are the available hazardous
Yes,
materials?
sir.
Hello?
Yes, ma'am Daisy, please proceed.
Yeah. Ma'am Renalyn, my question
Yes,
is,
ma'am.
what are the available hazardous materials in your facility and what are your protocols?
Usually, ma'am, for example, we have this cleaning chemicals for the cleaning stuff. Okay. So, for example, if any chemical is spillage, we have this code. We can activate code brown if the chemical spill exceeds 100 ml and above, and then the responsible team would be the cleaning staff, the supervisor of the cleaning staff, and also the security to secure the area in order that there's no further person or any other to be harmed from the chemical spillage.
Ma'am,
Again, ma'am. Your line.
That's all, ma'am. Anything else?
Ma'am Daisy, did you hear the
Hello?
answer?
The line is not clear. The last part, I didn't hear what she's saying.
Ma'am Renalyn, can you just repeat the last part that you were?
Last part, ma'am.
The last part, because
Hello,
Ma'am Daisy
Sir
wasn't able.
Wilson.
Yes,
Ako
ma'am.
na?
Yes. Can you please repeat the last part of your answer?
For example, if there is chemical spillage like more than 100 ml, we usually have this code team that, for example, we will activate code brown in our facility, and then the necessary staff like the cleaning staff and the security is the one who will attend this code to secure. For the security, their responsibility is to secure the area that nobody can go in this specific area so that they will not be contaminated or be harmed. And then the cleaning staff, they have certain protocols how to clean or how to remove the chemical spillage.
Thank you, ma'am. It's all clear.
Ma'am Renalyn, I'd just like to make a follow-up question with you. Your team, your hospital do have like the MSDS, right? Like the material safety data sheet for yeah.
Yes.
Yeah.
Yes.
So you use this as a reference to use any spillage or any chemicals that you have in the hospital.
Yes, sir. I forgot to mention we have this internal study. Yes.
Okay.
We are monitoring all the chemicals that are available in the hospital, and in every chemicals there are certain protocols to follow.
Thank you very much, Ma'am Renalyn, for that. I think I can only accommodate one more question. Anyone who last question before we end. Ma'am.
Sir, I want to ask a question.
Yeah, please, ma'am. Ma'am Rachel, right?
Yes, sir.
Yes, ma'am, please.
I want to address my question to Sir Charchai regarding the natural disasters. My question is, as a nurse in charge in ER department during natural disaster, what attitude are you willing to embody and express during uncertainty and stress?
Sir Charchai, please.
Thank you, Ma'am Rachel. As ER nurse, the appropriate attitude and advanced role is necessary to survive emergency situation during natural disaster. Especially the longer the disaster it will remain, the greater will be our exposure to stress and pressure. A nurse should first focus on what he or she is doing. Second, anticipate the worst scenario it will happen. And lastly, must have critical thinking and a good decision making. That's it.
Ma'am Rachel, are you satisfied with
Thank you,
the
sir.
answer?
Yes, sir. I'm satisfied.
I think that's it. I think we need to end the session because we already exceeded like 10 minutes already. Okay, thank you very much for the participation and for also for the speakers for all for accepting the invitation. I hope this will not be the last that you'll share your knowledge and expertise in this field of nursing. With that, I would end the session and hopefully to see you in the next one. Thank you very much and stay safe.
Yes, sir.
Thank you.
Thank you. Thank you, sir.
Thank you, sir.